Tony, thank you for that kind introduction. Thank you for the invitation. Absolutely delighted to be here. It's a huge honour. I have no conflicts of interest, genuinely, but my main interests are in diabetic kidney disease, and I work actually with GPs as well. So I do a lot of diabetes in primary care in East London. You can imagine in East London there's a lot of diabetes out there. We're here to celebrate William Osler, who is one of the greatest physicians that ever lived. And those of you that have read his biographies and so on will be familiar with his work. But I think that this quote, and I've got a number of quotes actually in my talk today, but this quote I think typifies the way that diabetologists work. I think is: the good physician treats the disease, the great physician treats the patient who has the disease. I learnt this from Tony Barnett many years ago, who was one of the most respected physicians that I've ever worked with, and an amazing doctor and a great mentor. So absolutely delighted to be able to talk to you about diabetes, and what I'm going to try and cover is a little bit about some hot topics: why type 2 diabetes is important, is glucose control important in diabetes? There's a huge debate around this. Then we've got a number of new drugs. So these are some new drugs that you might have come across, and there's actually some really good evidence around them. And then some really, really interesting advances in technology that are revolutionising the way that we manage, particularly type 1 diabetes at the moment. So we'll try and go through some of those. So the world's most populated countries. Number 1, China. Number 2, India. Number 3, diabetes. Okay, so you put all people with diabetes in the world in one country, it will be 400 million people, the third most populated country. It's a huge, huge problem. We're not immune from that in the UK. When I was a registrar with Tony in the 90s, we had 1 million people with diabetes. I mean, look at the growth, 4 million now, 5.5 million by 2025. That's 5 years away. It's really scary. In my diabetes clinics now, I mean, it used to be a little bit shocking to see a young person of the age of 18, 17 with type 2 diabetes. It's routine now. It's absolutely routine. The commonest cause of diabetes in children in Tower Hamlets, where I work, is type 2. It's not type 1. It really is quite scary. It's a tsunami of diabetes. And Nina Modi's talked a little bit about some of the causes of that, but clearly it's not just prematurity, it's also this obesogenic environment, courtesy of the main Olympic sponsors 2012, Coca-Cola and McDonald's, of course. But why does hyperglycemia cause complications? Well, I could furnish you with reams of data, reams of slides, but I think that actually this quote from the New England Journal was a really helpful quote that I use with my patients and with my students. High blood glucose levels are said to injure our organs like tiny pieces of glass, making microscopic cuts in blood vessel walls. And I think that's a really poetic and expressive phrase that we can use to teach our patients and our students how diabetes can really cause major havoc to people's lives. And when I'm in a diabetes clinic, I'm a neurologist to a podiatrist. I deal with the whole person, their psychology, their motivations, and so on. These are the sort of things that I might come across. So our patients have foot problems. The commonest cause of amputation is diabetes. The commonest cause of end-stage renal failure is diabetes. It costs £30,000 to £40,000 a year to dialyse someone. Heart disease, stroke, eye disease, commonest cause of blindness in people of working age. Perhaps these are less known: cirrhosis, NASH cirrhosis, third commonest cause of cirrhosis worldwide. Diabetes is an independent risk factor for cancer. So it's an independent of obesity. It's a very, very important risk factor for the development of cancer as well. So some things you ought to already know. We treat it with respect. 3/4 of our patients will die of cardiovascular disease. Those of you that use the Jubilee line today will be perhaps familiar with the concept of health inequality. So you lose 1 year of your life expectancy from Westminster to Stratford every stop along the way. So please make sure that you stay the west end of the Jubilee line. There's huge health inequalities in diabetes. So in East London, many of our patients are dying 10, 12, 15 years prematurely from diabetes and cardiovascular disease. It's myself as a South Asian, I've got a 5 to 6-fold increased risk of developing diabetes. That's by virtue of my genetics and culture and so on. Afro-Caribbeans also have an increased risk. Women with previous gestational diabetes and their offspring. Very importantly, the children of women with gestational diabetes also have a very much higher risk of developing diabetes themselves, obesity, family history, etc. If you have microvascular complications, you've got a much higher risk of developing cardiovascular disease. So if you've got a bit of retinopathy, a bit of nephropathy, you are already self-selected for developing cardiovascular disease, and it's costly. We spend $1 billion a year on diabetes drugs. You might have seen in the papers recently. We spend around about $10 billion a year on diabetes complications. So the vast majority of the expenditure of diabetes is actually on the kidney disease, the foot disease, the heart disease, the blindness, etc. So the major treatment is the cost of its complications, and there's a huge societal disability cost as well. So the great thing about being a diabetologist is that there's lots of things I can do to try and prevent that. So I can stop my patient from smoking. 1 = 5. So if you smoke 20 a day, you actually smoke 100 a day. So people with diabetes really must stop smoking. We can treat their blood pressure. We can treat their lipids. We can get them screened. We can also treat their glucose. And actually the shopping list of the things that we can do are probably in the correct order, actually. So smoking, blood pressure, cholesterol, in that order, screening for all those complications. Glycemic control probably is very much the lower part of that shopping list. NICE suggests that we should be getting tight glucose control, but individualized to the patient. But how low should you go? So this was a big debate, and Tony was involved in the UK PDS study, which I'm sure you're familiar with, the seminal study which suggested that actually tight glucose control does reduce the risk of microvascular complications. But this was a really important study that came out a few years ago now, the ACCORD study, which suggested that tight versus less tight control actually increased your risk of death. So going to really tight glucose control actually increased your risk of death by 22%. That was a really shocking finding to us in the diabetes world. And the reasons for that probably is related to the drugs that we use. So in this study, insulin, sulfonylureas, glitazones, they were used, and they probably do increase the risk of cardiovascular disease. We'll talk about other drugs shortly. This is another study that suggests that actually if you look at the glycated hemoglobin, you can see a U-shaped curve. The bottom of that U is around about 7.5%. As you go lower, then you tend to increase risk of developing death. So the great and the good have come up with a number of suggestions about what we should do about glucose control in a variety of areas, and suggest perhaps we should be going for tighter glucose control early in the disease, early in the patient's journey, perhaps in the first 10 years, 15 years maybe, and then later on perhaps allowing the glucose to be a little bit higher. NICE suggests very much individualized targets, and I think that's actually appropriate. We do look at our patient very carefully. We negotiate with our patient what going for lower or tighter control means, what adverse effects might happen, and we take into account their comorbidities. Tight glucose control in an elderly person with cardiovascular or renal disease is probably not going to benefit them and may even cause significant harm. So glucose control, there is a debate around this, and trying to individualize our treatment for our patient is really the crux of the matter at the moment. So let's have a think about how we might treat diabetes now. So this is not me, actually. This is, I recognize it looks a bit like me, but it's a 46-year-old South Asian man who attends a diabetes review. He's had diabetes for 4 years. He's a taxi driver. He's a little bit sedentary. He doesn't have good glucose control. That's about 8.5% in old numbers. And slightly worryingly, he does have some proteinuria. So an albumin-creatinine ratio is elevated. He's got some albuminuria. That's telling us that he's got some kidney disease. He's on high-dose metformin. His blood pressure and cholesterol are well controlled. What are the next glycemic agents? Well, when I was working with Tony, we had probably about 2 or 3. So we had sulfonylureas and we had insulin. Then we had glitazones, and then we got a number of newer agents that are available to us. And I think it's worthwhile just telling you about some of these newer agents. But let me just remind you about these older agents. This is another Osler quote, what I really like. The person who takes medicine must recover twice, once from the disease and once from the medicine, which I think is a fascinating quote. But yeah, I mean, certainly we've got many medicines out there that we can use for diabetes now. So the older drugs, metformin is good. I mean, metformin is an important drug. We have shown a mortality benefit in obese type 2 diabetes in the UK PDS study. We start slow and titrate. We can use it down to GFRs really quite low now. This is really sort of CKD stage 4 now. We continue it when commencing insulin, and we use it routinely in gestational diabetes now. In women with gestational diabetes, it's a very, very useful agent and can reduce the risk of hypoglycemia and so on. So sulfonylureas are a bit of a concern. These are a very old class of agent that are available to us, very, very helpful in terms of lowering glucose, but they cause weight gain, they cause hypoglycemia, and there's special concerns in the elderly in particular. We certainly recognise now that actually many elderly people have hypoglycemia causing falls, causing hip fractures, and so on. So sulfonylureas we need to be a little bit careful with, perhaps thinking about them lower in the treatment pathway. You may have come across glitazones and lots of reasons for prescribing them. So they're oral, they're once daily, they're well tolerated, but lots of disadvantages. They cause heart failure, they cause an increased risk of fractures, they cause weight gain, possibly, although this is probably unlikely actually, a link with bladder cancer as well. So glitazones, these were a class of drugs that we were using quite a lot of, got a bit stung with them because of the heart issues, and we're using less of them perhaps in recent times. Insulin, we use still a lot of insulin in patients with diabetes. The natural history of diabetes is that patients' beta cells fail over time, so often we do need to give insulin. It's generally well tolerated. We can get good glucose control, but it's an injectable. It needs a lot of support from our diabetes nurses. Blood glucose monitoring, hypoglycemia, and weight gain are all issues with insulin as well that patients just don't like. These are things that people don't like to do and don't like to have to them. So it is a bit of an issue. What about these newer drugs? So these are the drugs that are not that new, actually. They've been around for a little while now, but the glucagon-like peptide 1 analogues. These are an interesting group of drugs. So the incretin effect is a fascinating effect. So this is the insulin stimulatory effect. So this you can see the insulin levels according to whether you have oral nutrient, and oral is that top one, and this is intravenous nutrient. So intravenous glucose here, and oral glucose here. You can see that the insulin stimulatory effect is much greater if you take oral glucose as opposed to intravenous glucose. And that effect is called the incretin effect, the increased insulin effect, and it's modified or modulated by glucagon-like peptide, which is a hormone produced in the L cells of the small intestine. So this is a hormone that is stimulated when you have food, or even when you look at food or smell food. It stimulates insulin release from the pancreas, and very, very importantly, it reduces your appetite. So it's telling you, it's a signal saying that you've got food coming, you don't need to have quite so much. Very importantly, in people with diabetes, you can see in the stars here, the incretin effect is very significantly reduced. The reason that I've got the Gila monster here is that the first GLP-1 analog that was produced from the saliva of the Gila monster. The Gila monster can produce this substance called exendin-4 in its saliva, which enables it to stop eating for 6 months, doesn't have to have any food for 6 months. And my wife tells me I should do this occasionally, and it might save us a bit of money. Yeah, I mean, this is an extraordinary beast. And this substance, exenatide, was the first GLP-1 analog that we have. We have a number of them available now. The main one we use perhaps is liraglutide or Victoza. These are injectables, they're peptides, so they have to be given as injectables, but some of them are weekly injectables, so you can actually give them once a week to patients with diabetes. NICE guidelines are fairly strict at the moment, so they say that we have to be giving them to fairly overweight, obese patients now. We can we've got a bit of a fudge factor to give them slightly in less obese patients if there's a weight loss or would benefit obesity-related comorbidities. The adverse effects that Osler alluded to are predominantly GI, pancreatitis, pancreatic cancer. There's not really any convincing evidence of that from post-marketing data. And we should be using these for 6 months and seeing their effect. They're expensive drugs. We shouldn't continue them unless the patient is responding well to the treatment. And very, very importantly, we have some more recent data now suggesting that these are very important, useful drugs for reducing cardiovascular and renal disease in patients with diabetes. So the LEADER study and the SUSTAIN-6 study showed a very significant reduction in major adverse cardiovascular events in patients on these drugs and cardiovascular death as well. So some very positive data to suggest that these drugs might be very helpful. The DPP-4 inhibitors are linked to the GLP-1s. This is the enzyme that actually breaks down your endogenous GLP-1. This inhibition of this leads to increased levels of endogenous GLP-1, and we've got the gliptins that have been available to us for a little while. They're oral, they're once daily, they're weight neutral, very few side effects, very useful drug to have, but a bit like Brexit, there's no evidence of benefit. Sorry, apologies, we're supposed to be in Purda, aren't we, at the moment, but I couldn't resist it. There's no evidence for these drugs for cardiovascular protection. So they're cardiovascularly neutral, they don't increase the risk of cardiovascular disease, but there's no benefit in terms of long-term heart protection. They're moderately effective. You might get a slight reduction in glycated hemoglobin, but they're very rarely sustained. So they're not a drug that we use a huge amount of. We might use them a little bit second line, but these are the drugs that are really growing in interest in the diabetes field at the moment. The sodium glucose transporter 2 inhibitors, the gliflozin. So these are drugs that block in the proximal renal tubular cell the sodium glucose transporter 2 inhibitor. Fortunately, the sodium can be reabsorbed later in the distal convoluted tubule. The glucose is lost and you induce glycosuria. And as you can imagine, inducing glycosuria is quite good. It's good to lower glucose and to lower weight. But of course, the adverse effects might be urinary tract infection and thrush, but you can see an improvement in glucose control and, very importantly for our patients, weight loss. So this is a drug that induces reasonable amounts of weight loss in our patients. Side effects, you can imagine, urinary tract infections and candidiasis are a problem. Dehydration with diuretics is also an issue. And we have to take care in renal disease, although there's some recent data, and actually the FDA in America have now allowed us to use these drugs down to an eGFR of 30 because of data that I'm going to show you shortly. And then there's also this slight worry about minor amputation. So one of the drugs, canagliflozin, there was a slight worry about an increased risk of minor amputation in one study. It's not been reflected in a number of others, but slight worry that might be an issue. This is the exciting data that I alluded to. So this is the EMPA-REG study. This is a drug called empagliflozin versus placebo in patients with diabetes. And you can see here that you can see a separation of these graphs very early on, literally within a space of a few weeks. You can see a separation in cardiovascular death. So this is cardiovascular death, a 38% reduction in cardiovascular death. And this is this was a big surprise to us in the diabetes field. We weren't anticipating this, but really positive data to suggest that these drugs are cardiovascularly beneficial in patients with diabetes. We've also got studies using another drug called canagliflozin showing similar data as well: heart failure, cardiovascular disease, stroke. All of those are significantly reduced. And you can see here that actually these are comparable. So the reduction effects are comparable to statins and ACE inhibitors post-infarct. So this empagliflozin in patients with type 2 diabetes at high cardiovascular risk, very very reasonable numbers needed to treat to reduce one event. So quite impressive data. In terms of renal effects, this is a huge interest to me in my diabetic renal clinic. I have one of the largest diabetic renal clinics in Europe, actually, in East London. It really is quite scary, the number of patients we have on dialysis. But this is a drug that will reduce progression of cardiovascular disease. So in a recent study, 44% reduction, doubling of serum creatinine, reduction in macroalbuminuria, and a 55% reduction in end-stage renal failure. Really quite astonishing data. Again, not really expected. And it's been replicated with other drugs in this class as well. So this, I mean, people are talking about this being a new paradigm in diabetic renal disease. So we're talking about, we've always given ACE inhibitors first line. Maybe we should be thinking about these drugs as well. It's unlikely to be rated to glucose control. I showed you the separation of those graphs very rapidly early in the study. Is it just blood pressure and weight loss? These drugs do lower blood pressure, they lower weight. There's other suggestions, something called tubuloglomerular feedback, which I don't have time to discuss, but there's other mechanisms suggested as well. So this is a new paradigm that's being suggested in diabetic nephropathy, ACE inhibitors plus gliflozins in patients with established diabetic nephropathy. So our gentleman with this proteinuria, certainly the second-line drug now would be a gliflozin in this gentleman. Absolutely no doubt about it. And that's a substantial change in recent times. And we're certainly starting to do that much more than we over the last months since these studies have come out. Just to mention to you again, as Osler alluded to, some of the sort of slight concerns about these drugs. So this gentleman starts a gliflozin. He takes his GP takes a call. He's got abdominal pain, nausea, and vomiting. GP should assess him. He comes to the surgery, looks unwell. He's hypotensive, tachycardic. His glucose isn't too bad, and his abdomen is soft and non-tender. And the advice to the GP should be that actually what he should have is he should have a test of his urine ketones, because this is a drug that can occasionally cause a condition we call euglycemic ketoacidosis. It's very rare, but you can see here acidosis, reasonable glucose, it's not too high, high level of plasma ketones. This patient has a condition called euglycemic ketoacidosis, which is a condition that we do see occasionally, and we've certainly seen 2 cases at London in recent times of this drug inducing this condition in our patients. So there's going to be a whole education piece going on for our patients and for our primary care colleagues about managing these patients in the community. So whilst this is a very rare complication, it is something that we need to recognise as a potential. I apologise for this slide. It's a very complex slide, but just to explain to you that we have some new guidelines from the Europeans and Americans. We're hoping that the NICE guidelines might update them as well, but they're suggesting that these newer drugs should be much more for second line after metformin than they used to be. If cost is a major issue, you can still use sulfonylurea and thiazolidine dyes. Cost is, of course, a major issue in the UK NHS, but I suspect we will be using these newer drugs much more earlier in the therapeutic pathway in our patients in the future. To finish off, I'd just like to tell you about a few recent important advances. So we'll just think about remission of diabetes, a bit about glucose monitoring, and a bit about the artificial pancreas, because there's some fascinating stuff going on about these. So just in the next 5 minutes, I'll touch on these areas. Another Sir William Osler quote: "One of the first duties of the physicians is to educate the masses not to take medicine," which I think is a wonderful quote as well. So what about this gentleman, 43-year-old man, type 2 diabetes for a year, he's overweight, he's got poor glucose control. I don't want to take tablets, doctor. Has he got any options? Well, from a recent study, he probably has. So this is the DIRECT study, the Diabetes Remission Clinical Trial. Inclusion criteria, fairly recent diabetes and fairly overweight. The endpoint was to try and get weight loss, 15 kilos, and remission of diabetes. And the intervention was the control group was just standard best practice in primary care, and the intervention was to stop anti-diabetic and anti-hypertensive drugs and go on to a special diet called the counterweight diet, which is essentially 4 milkshakes a day of a total of 800 kilocalories for a period of 12 weeks. Okay, so the intervention was to have no food whatsoever and only have milkshakes for 12 weeks. Now, I don't know how many of you in this room could do that. I certainly couldn't, but it's quite an extraordinary thing that what the patients managed to do in this study. They had a food reintroduction thereafter, a weight loss maintenance up to 52 weeks, and the 1-year data has been published a couple of years ago, was extraordinary. So you can see here a mean weight change of 10 kilos, that's the mean weight change. You can see a glycated hemoglobin reduction of 1% or 10 or 11 millimoles per mole between the 2 groups. Almost a quarter of the patients lost 15 kilos in weight with this program by 1 year, and 46% of patients went into remission from their diabetes. Almost half of them went into remission from their diabetes. Quite extraordinary data. Drug discontinuation in 3 quarters. So the conclusions of this study, and actually the very important fact, was that this was done in primary care. This was a primary care study run by practice nurses in GP practices. And you can see here that a significant number of patients can achieve remission of their diabetes. 2-year data looks very positive as well. I think the 2-year data is looking at around about 34% have remained in remission. So really quite extraordinary data to suggest that actually looking at weight loss as a means to try and put diabetes into remission is feasible. Yet another Osler quote, the future, this is the last one, the future is today, and it very much is with the next couple of slides. So I'm sick of testing, doctor. I hear this all the time in my clinic. Is there any option for our patients? Well, there might be. So this is a wonderful new way of testing your blood glucose. This is called the Freestyle Libre. So you can see here a glucose sensor that's on the arm here. This lady has to change this glucose sensor every 2 weeks. It sits and measures subcutaneous glucose. And you've got a little glucose sensor, meter that you just literally put over it, and you can read your glucose reading. Extraordinary, life-changing technology for patients with type 1 diabetes. At the moment, sadly, we can only use it in very restricted patients. It's costly, and we can only use it in type 1 diabetes with other problems. So if a patient can show that they're testing more than 8 times a day, then actually it becomes cost-effective to use this. If they've got some sort of disability, for example, blindness, or if they've got problems with hypo-unawareness. But I suspect that we'll be starting to use this much more in type 1 diabetes over the coming years, where people with type 1 diabetes are testing 4, 6, 8, 10, 12 times a day. And this has revolutionized their lives. It really has made a quite extraordinary change to their lives. So the people who are lucky enough to get it are really finding it an extraordinary change. Now, what about this? This is, I sadly don't have that many people with abdomens like this in my clinic, but one or two. But this is an insulin pump here. So continuous subcutaneous insulin infusion, CSII. This is delivering insulin subcutaneously here. And this is a continuous glucose monitoring sensor, CGMS. So we have, it doesn't take a huge leap of the imagination to see that if you could link that to that, that you would have an artificial pancreas. It doesn't take a huge leap of the imagination, but it's easier said than done. But we are making very significant progress. So Roman Havalka in Cambridge and the group in Boston have really got some amazing data to show us now on people who have living with this system with an algorithm that can link the two together. Essentially closing the loop is almost here. We now have a device on the market called the Medtronic 670G, which is available. We have studies suggesting better control, better quality of life, fewer hypoglycemic episodes, people free living, not having to do any glucose testing, not having to do any injections, free living with an artificial pancreas. We have this happening at the moment, and type 1 diabetes is on the cusp at the moment. It's just about to change. The management of type 1 diabetes is on the cusp of undergoing a revolution, and it really is quite remarkable what's happening at the moment. Still lots of things, lots of hurdles to cross, faster insulins, better glucose accuracy. There's a bit of a sensor lag time. We need algorithms that are never going to fail. If people are not going to test their glucose or give insulin, we have to know that these systems are never ever going to be failing. We have to have systems that can't be hacked. There's a whole worry about whether these technologies can be hacked and someone given an overdose of insulin, these sort of things as well. But one of the things that's happening in the diabetes community, and we have very active patient communities in diabetes, is that there's a whole community saying we are not waiting, and there are people who are hacking these devices and actually managing to do them themselves. So even without the NHS, they're managing to manage their diabetes themselves, and a whole group of, a patient group of patients who are managing to do this extraordinary business. Just a few things about newer drugs. We've got a number of new drugs in the pipeline, so we've got even longer-acting GLP-1s, monthly, maybe even yearly injections of GLP-1s. Oral GLP-1s are available as well. We've got weekly DPP-4s, insulin GLP-1 combinations, and glucagon receptor antagonists. So diabetes is a great, fertile field. I mean, the drug companies are clearly very interested in this field because once they're on these drugs, they're generally on them for life. And you've seen the numbers of people with diabetes. I haven't had time to talk to you about prevention of diabetes. This is a whole other sort of area that we need to really focus on because we've got a huge problem in the UK, and we're going to have to grasp that nettle at some stage. So to finish, some takeaways for you, my last slide. Diabetes is getting very much commoner, and cardiovascular risk reduction is mandatory. Metformin to everyone, if we can, with type 2 diabetes, unless not tolerated or contraindicated. Tight glycemic control might be important early in the condition, But we must individualise that target, we must discuss it with our patient, we must look at their comorbidities and see what is an appropriate target for glucose. Weight loss can lead to remission of diabetes, well, that's demonstrated in an important randomised controlled trial. We've got newer treatments for glycemia which offer important therapeutic options and appear to be reno and cardioprotective. Thank you for your attention.